see people still entering, but we're going to go ahead and get started so that we can get to everything during our session today. Welcome to everyone. Thank you for joining us for our August faculty development session. I'm Dr. Jessica Seaman, Academic Success Consultant for GME and the co-chair of the Faculty Development Committee. Our committee really strives to create and deliver effective sessions that develop our diverse faculty, which is all of you. And we want to develop our faculty as leaders in clinical care, medical education, and research excellence. And we have a very timely presentation today, Teaching in the Era of COVID-19. And this will be delivered by our other committee co-chair, Dr. David Wisinger. Dr. Wisinger is also the Assistant Dean of Faculty Affairs for Creighton School of Medicine and Chairman of the Department of Medicine at Valleywise Health. We will be recording this session for future reference. We will be getting that out to all participants, and we invite you to submit any questions you may have in the Q&A tab rather than the chat. We do have a Q&A on this webinar, and we will be monitoring those questions throughout the presentation and answer as many questions as we can as you ask them, but also at the end of the session. If Dr. Wisinger can answer any of those questions, then we'll make sure that he sees those. So Dr. Wisinger, if you are on and ready to go, I'll go ahead and turn it over to you.
On the Teaching in the Era of cover slide, can you see the second slide that says overview?
No, just the title slide. Oh, there you go.
So Teaching in the Era of COVID, what the heck just happened? I want to try to make this a brief discussion, not just necessarily on the modalities that are being implemented to try to overcome our ability to be in person when we're teaching, but to talk about some concepts related to teaching and how they can be applied in this more virtualization that we live in at the moment. So today's overview will look at some of the history of what's happened in previous pandemics, and yes, this has happened before. Pedagogy, intelligence approaches, online and remote teaching, some examples of what's been applied out in other places, a bit on COVID psychology, and some conclusions. If you can see this slide, you see what life used to be like to an extent, where we could be together without having to socially distance, wear masks. And of course, it's always great to know that all our learners are as attentive as these two young ladies are to the preceptor in the slide. And please remind me if you're not seeing this, tell me now. This is today, where obviously there's a lot more PPE involved, and even seeing numerous people together with PPE with a patient is an unusual circumstance, certainly in the learning environment, since we've had a lot of effort made to minimize contacts between learners and teachers and trying to conserve PPE, etc. And we'll talk about the value of that or not of that shortly. Have we been here before? The answer is yes, to an extent. Those of you out in the audience are probably mostly younger than me, but I was around in the early 80s as a student when HIV hit San Francisco, New York, and Florida heavily. I was in South Florida at the time in medical school, and at that time medical students were actually told to see, quote, those patients. Attendings rarely saw the patients. They felt as though they had little to do with them from a psychosocial perspective. Also from a treatment perspective, there were limited options as what you can do to help these patients. And I guess at that time, medical students were not necessarily felt to be expendable, but there was zero interest by many to have the students be protected, if you will. We did wear gloves, didn't know whether to wear masks or not. It was a scary time because people knew that if you acquired HIV, it was uniformly lethal. And the other interesting part about this, which will go into some of the professionalism pieces I'll talk about later, is attendings were often very open, as were other healthcare staff, about their opinions that were reflective of what the community felt about people who acquired HIV, which was predominantly amongst the gay community, injection drug using community, obviously underserved people predominantly as well. And so a lot of biases that came out very intensely during that time, which was very interesting to watch as a student and definitely affected me quite a bit as I professionally developed. People may or may not remember much about SARS, which came out in the early 2000s, particularly in Hong Kong. There were medical students who were unknowingly infected, and clinical teaching was suspended right away, and community teaching amongst the primary and secondary schools in Hong Kong was subsequently suspended. What was interesting is the medical school in Hong Kong that I'm referring to there had problem-based learning and was using PowerPoints using the lecturer's voice to substitute in for group sessions that they implemented actually pretty quickly. They were actually looking also at trying to implement chat rooms, but never got around to that because kind of like what Trump wished would happen with Corona now, the virus somewhat magically disappeared relatively quickly, at least in terms of affecting the wider public. And so it was not having to be modified other than the initial PowerPoint presentations. But what was interesting, though, is that the schools right away used their healthcare professional trainees, nurses and doctors being trained, and pulled them off of wards and used them to facilitate public health education, particularly at public transportation posts. So they were definitely trying to engage students into the public health arena as an adjuvant to providing care to patients. But again, interesting phenomena that SARS did not promulgate around the world as COVID has, nor last obviously terribly long. But it was interesting to note that a coronavirus could go rogue, which is what happened, of course. So pedagogy is the art and science of profession of teaching, really talks about the method and practice of teaching. And so you'll hear that term used, and this is the context of which I'm using it. But I want to really say, though, is that over time, in the last 10 years or so, many medical schools and actually other healthcare professional training sites have been trying to reduce more of the traditional didactic lecturing format and trying to use technology to enhance some of these experiences, whether they were in anatomy labs, using them in team-based learning where you had the use of standardized patients, promoting interprofessional education, etc. In other words, there was a lot more being done to have a collaborative approach to teaching, which of course required a lot of personal contact. Obviously, that has changed quite a bit. Problem-based learning, which is a methodology that is used in many universities and medical and nursing schools in particular, and more recently been implemented at Creighton, is really designed to try to get more of a problem-solving modality in place with students, teaching them how to be interprofessional and interdisciplinary in their interactions and to share those knowledge sets when providing the care or devising care plans for their patients. So again, it's more of a community-based learning, if you will, which of course requires contact to work best, although we're going to talk about how there may be some ways to overcome that. Case-based learning is more specifically designed around specific clinical cases, real-life scenarios. But again, the intent there is to have critical thinking and communication take place as a group, which tends to work better, of course, in person. So now we've got our focus to be mostly on remote or virtual learning because we're now not able to be together as often as we were. And there are certainly some subjects that can be done that way, in a didactic way, virtually, probably without dramatic change, things that are more factually discussed. But you clearly can't group learn, perhaps be involved in laboratory sessions where you have groups of people there, and even the use of standardized patients may have some limitations clearly in this new paradigm that we're in. And so while this is kind of getting rolled out very abruptly amongst many healthcare professional scenarios, how effective it is, how well received it is, et cetera, is to be measured. So there's opportunity for scholarly activity related to this, and certainly that's ongoing now, although what you see currently in the literature is very small numbers, and measurements, and how to measure this is actually still evolving. And of course, student involvement with COVID patients is a key component of how it is we teach them. And certainly initially, as we mentioned, students were uniformly basically removed from the clinical care arena where there was an opportunity potentially to get engaged with COVID patients. That's beginning to change now, which I favor, and I think has allowed students to see not only the pathology of COVID, but really also to kind of learn how interprofessional disciplines can work together to solve what is a crisis that was thrust upon us fairly quickly and still provide effective, reasonable care to patients and still learn. In other words, clinical teaching has to be done clinically, which is often at the bedside. Now you're wondering, why the heck would we be talking about theories of multiple intelligences? But I'll tell you why here, hopefully shortly you'll catch on. So remembering that teaching was done historically, obviously, in person, right? Whether it was in a didactic session, which is a little bit more traditional and old-fashioned, but even as we morphed into more of problem-based, case-based learning formats, where there was an emphasis on interpersonal interaction, interprofessional utilization of skill sets, etc. As an effective teacher, you need to, in my opinion, be able to kind of assess your learners as to what styles and approaches may fit them best, because people are very different with how they learn. You could argue that learners who are in like disciplines, such as nursing, such as therapies, such as medicine, etc., may have a more congruent set of intelligences. They by no means have the same intelligences. Intelligence really meaning how it is that they learn. And individuals don't generally have just one single maximum intelligence. They often have mixtures of them, some more dominant than others, but they are very different. And those intelligences are felt to be people who are more visual in how it is that they learn, people who are more linguistic, right? So people who are more effective expressing themselves in writing and reading, people who have higher emotional IQs, EQ as we call that, where they are more interpersonal and tend to be more receptive with regards to their learning if they're working in groups and working with other people. Others may be the opposite. They tend to be more reflective and focusing on their self-evaluation and may not do as well in larger groups. Some people are very methodical, very linear in their thinking, mathematical, if you will. Others may be more musical, maybe more athletic or kinesthetic, and some are more naturalistic, and they may be able to kind of see, if you will, the bigger picture with regards to how man lives in society, etc. Not all these intelligences are meant to be focusing on healthcare professionals, but if you're experienced as a teacher, you clearly know that you've come across many learners over time who have different degrees of these intelligences. And if you want to be a more effective teacher, you should kind of key into these and see where it is your students may actually have a better chance to pick up what it is you're trying to get across. That's been updated a little bit more recently with the feeling that there may be some learners that are naturally good teachers. And they have an ability to basically be more efficient in their learning by being engaged in teaching. And again, if you're a successful and good teacher, you tend to be somebody who's obviously a lifelong learner and adapted to that. And then, of course, now that life is a bit, or I shouldn't say today, but certainly over the last number of years has become more digitized, if you will. There are some people who are more naturally adept at using virtual and digital technologies to learn as well as teach. And that, of course, is coming to play today. We're going to skip past this just briefly because it's a bit redundant, but I want to kind of point out that what were some of the initial reactions in the world when the pandemic hit, and how did they adjust? And some of those adjustments are obviously personal adjustments. Some of those adjustments are information technology-based adjustments. You know, in China, there was an extension of cloud servers through the Alibaba cloud, Jack Ma, for any of those people who know him, and they were able to dramatically increase their capability to accommodate a tremendous number of people needing virtual interactiveness, particularly with regards to learning. Another example that took place pretty quickly was the LA Unified School District teamed up with the local PBS station and started offering some educational broadcasts, some of which was geared towards particular ages depending on the time of day associated with other TV shows. And so it was a very unique kind of a partnership between the school districts and public television, which I think was very important on two fronts. The first being that you had a way to try to get into the households of people whose children were watching TV, and recognize that, most of you know by now, I hope, that not all people in society have the same access to the electronic age, if you will, to allow them to participate digitally. This is a nice cartoon that shows perhaps the Anglo kid in the rich suburb basically being able to do many things from home now, maybe not quite so good to the underserved population who may not have this access. And yet that has been dramatically shown, obviously exacerbated, if you will, by the pandemic. Talk about why this matters to us as healthcare professional educators. So OE, online education, people are aware of, has been around for a number of years. If you remember something a la the University of Phoenix, if you will, which came around and really tried to heavily invest and develop online education resources for community workers, as it were. That took a long time. It took a lot of design and planning. It took a lot of upgrading. And the point being is that with adjustments and not only in changes in technology, but the ability to kind of understand what works and doesn't work, it's a modality that takes time. Faculty have time to develop comfort using these systems, and there's often, because it's rolled out in a sequential, planned way, IT is able to scale up to accommodate what's necessary to make it work well. So those types of platforms we call online education are going to come to be in the medical world, and they already are there in some places, but we have now engaged in what we call emergency remote teaching, which is, oh my gosh, there's a pandemic in March, we got to get a lot of stuff online, we got to figure out how to teach our learners remotely, etc. And so it was really stuff just kind of thrown together. And the key at that time was to say, just get it online, somehow, some way, figure it out. And that's still ongoing now, and part of that's ongoing now because the sheer volume of need to do this across the United States is impressive. Two, you're still dealing as healthcare professionals just trying to deal with the surge of patients who were sick, and I can tell you, certainly from our perspective, and I know many of your perspectives, we were just incredibly busy over months trying to deal with what was a disaster, and it was just get it online. The ability of health systems to accommodate that from an IT perspective was challenged because they were also called to the front lines to try to make this work and deal with, problems that occurred from an electronic perspective. And people were designing things kind of on their own. To quote Ray Bradbury, living at risk is jumping off the cliff and building your wings on the way down. That's how it felt and kind of still feels sometimes as we're going through this. I mean, just look at me just 20 minutes ago trying to get online here. And then finally, you should, whatever you have going on now with regards to methods trying to deliver content to learners that you feel can be done virtually, and again, I'm trying to make the case here shortly that this cannot be done just virtually, view it as temporary and continue to try to develop it. And don't forget to engage your learners in the development because they actually have a lot to offer, which we'll talk about. So live versus online, as I kind of mentioned this before, the value of being able to work intimately with your learners is, in my opinion, invaluable because there's a lot of a dynamic flow of interaction that takes place that cannot take place well virtually. I don't care how many boxes are on your screen, how many times people are looking at the camera, trying to behave properly. Certainly now, I can't even interact with you verbally because you guys are all muted off while I'm talking, although we'll have questions and answers here shortly, hopefully. But the point is that there's a lot lost in the teacher, the educator's way to be able to assess what it is the learners are thinking and how they're learning, as I talked about earlier with those intelligences. You have difficulty having transitions in subject matter and talking. I can't read the room. I can't read the room now to tell who's, doing what or whatnot. And you can't get learners to participate with each other. They're not even chatting necessarily all the time. The chat box is kind of cool, but pretty sluggish and slow and not very helpful. And of course, trying to actually reach out to people to have warm or cold calls Warm calls being people who are already engaged in discussion and you're asking them questions. Cold calls are when you kind of reach out to somebody who seems unattached and you're trying to get them back into the fold by asking them questions. They call that cold calls. So things have changed, obviously, with the COVID, and we just talked about some of the detachments with the learners, how to use students, engage them in their learning, et cetera. And there's another paradigm change that's been noted dramatically. Back in the day, it was somewhat looked upon honorably, it's a relative term, to physicians and other healthcare workers who would come to work even if you were not feeling well, right? The idea is you're just so committed to your patients, you would come in and do the best you could. It was felt to be a very altruistic and professional trait to have. And, to some extent, there probably was some truth to that in terms of a willingness to trudge through no matter what. Although, obviously now, with the pandemic, you can't do that. If you've got illness of any type, you stay home, you get evaluated, et cetera. So the culture of professionalism and altruism may need to be redefined, as it were, which I think it can be. The point is that COVID-19, if not necessarily in the massive wave that occurred just recently and may occur again this winter, is likely going to be with us as a clinical syndrome for a long time, and we will have to learn to not necessarily be uncomfortable with situations where people are manifesting with potentially communicable diseases. We've done it before with HIV, we've done it with tuberculosis, and other communicable diseases. We will get there with COVID-19. But I will say that learners look to their educators a lot for professional and altruistic traits, and I think that putting the patients first and foremost is what we have to do, as difficult as it is, and I will be the first to admit that there are times when I'm uncomfortable in certain situations, but you have to plow ahead because you have to lead by example. So has there been any way to kind of leverage this current crisis to have learners perhaps pick up other parts of how you take care of patients differently than we had pre-COVID? Thomas Jefferson University decided to have their senior medical students on the cardiology rotation get engaged actively with virtual contact with patients who had recently been discharged off the cardiology service. Now, during the rotation, they were still receiving some didactic sessions virtually, but they were assigned to patients that had been discharged from the CV service in the hospital, and they were assigned to follow these discharged patients using standardized set of questions, focusing a lot on the interval history of how they're doing, compliance of their disease process, medication reconciliation, et cetera. And to be honest with you, these are pieces that I find very often are short-shrifted with regards to educating practitioners as to what's important. Is it important to know the pathophysiology of disease? The answer, of course, is yes. However, it is pretty meaningless to know that if you have patients who either don't understand their disease, aren't comfortable with what it is you're trying to do, your goals of therapy in general with regards to medication and follow-up, et cetera. And this is a great time to emphasize those quote-unquote softer points, although they're not very soft, and how important they are in healthcare. And so this is an opportunity, not to be lost, to have students participate and understand these are important, taking care of patients, and of course documenting it in the EMR. So again, not to basically have it be where the students feel like they're getting not to do the blood and guts of healthcare, but understand that these non-pathophysiologic elements are very important and need to be addressed, if you will. Another thing that comes out of the learning, besides understanding some of these other components of healthcare, the social determinants of healthcare that students need to be more focused on, as well as us as educators need to be focused on, there's also value in trying to learn what is the importance of communication, history assessment, et cetera. And this will take place, obviously, if more of your life is done virtually. So listening becomes really, really important. It's always been important, but I'm not sure it's always been felt to be important. And you're relying a lot on the history and what patients tell you. As I always tell students, patients are telling you what's wrong with them. We just have to learn how to translate it into what we can understand. The other piece on that is the importance of really listening to them to hear what they are or are not doing, particularly when it comes to medication and lifestyle changes and so forth. As people know me well, understand that I've always said if patients ever took all the medications that were on their list, their med list, they'd be dead. So lucky for them that they don't do that, because we just keep prescribing. We don't actually find out why they're not taking meds and so on and so forth. So there's a lot to be said to listening. And you can certainly, because of what you are finding out now with this new way of assessing patients in the outpatient setting in particular, a lot of practice improvement projects, scholarly projects can develop. And I think that those soft areas of healthcare with regards to patient compliance, et cetera, will take on a more prominent role. And so I think that's something we should not dismiss going forward. Learners look to you for guidance, your professionalism, your altruism, your willingness to listen to patients, et cetera. And they also look to see how you're dealing with this, right? So resilience is a component that not all people have equally. And it is the ability to recover, grow, and thrive during adversity. This is clearly a very adverse time. It's felt that professionals, healthcare professionals in particular, apparently have a remarkable amount of resilience. I think there's some truth to that, but maybe not as universal as we think. And a lot of us are trying to think how we're getting through this, and are we getting through this, and do we have enough insight and humility to understand there's sometimes when we're not getting through this very well and can reach out for help. Resilience is somewhat teachable, and you can learn some skills talking to healthcare professionals about how to cope with some of these changes. As I tell my wife every day, I really feel like this is Groundhog Day. You get up and you're kind of grinding through the same thing in the same environment. And to be honest with you, there are a few things that are positive right now, although the positive fact that we're having fewer cases of COVID is actually encouraging, but you keep getting the sense that the next bomb is right around the corner. So there's no choice but to adapt. This paradigm is going to be in place for a while. Online education clearly is what we're going to be doing, but it should only be a part of what you're doing. I will tell you on a personal note that I have always been somebody who felt I was never comfortable talking to our teams, our medical teams, when I'm on the floor in front of the computer. We go to the bedside. The computer is with us just to put in orders or to look up data points, but the discussions are always at the bedside and always with the patients because they need to be engaged. They tell us a lot that we don't know, that we think we know. And it also allows us to keep teaching them day after day about their illness, which becomes more likely to plant into their brain the more they hear it. Plus, I think it just allows practitioners to know that we shouldn't be talking behind the patient's back. If we got something to say, they should be able to hear it and so forth. So I think the bedside teaching is really, really important. Can you do that in the era of COVID? The answer is yes. Certainly better now with fewer COVID patients than we had just 4 weeks ago when a lot of patients had COVID and students weren't participating, but the residents were. And you could still do things at the bedside. So bedside is very important. So online education is clearly a major part of what we're going to be doing more so over time. But I want to stress that at any point possible, I think bedside community teaching, if you will, is really, really important. And as I said earlier before, this last point on this slide is let the young help us devise some teaching paradigms. They know a lot with regards to at least the mechanics, logistics. Let's use them as team members to develop and not just have stuff thrust upon them. You've heard the statement, never let a crisis go to waste. It was attributed to Churchill, Rahm Emanuel. I don't know if you guys are political, know who he was or is. There was a physician who had an article titled, Don't Waste a Crisis, Your Patients Are Your Own. Chinese proverb has actually been unearthed that showed crisis is opportunity. The point is, I don't really care who made it up. The thing is things happen, and when they happen, you have to find the positive in them in terms of improving how it is we do what we do. We cannot make COVID go away for now, so let's try to take advantage of what's happened to improve how we do what we do. And finally, just as a closing comment, look for the helpers. Fred Rogers, everybody knows Mr. Rogers, who did pass away not that long ago. When I was a young boy and would see scary things in the news, my mother would say to me, look for the helpers You will always find people that are willing to help. I think it's very important for learners to see the teachers grinding through this, moving forward, moving towards the patients who need our help, moving towards the other healthcare professionals who are really in the trench doing work and doing this together. They need to see that we're not at home solely, and we're not solely just speaking to them virtually. They need to see us doing healthcare with the community of healthcare givers, the helpers, if you will, as well as the patients. I think it's very important going forward for sure. And these are some resources available from some large groups as the American College of Physicians and the AAMC, et cetera, and the LCME. Okay, I will open up for questions if that's possible. God only knows if it is.
Yes, Dr. Wisinger, I'm going to go ahead and monitor any questions and answers.
Thank you.
That we can put in there. So if anybody can put those in the Q&A, please, if you have any questions. And then we can get those to Dr. Wisinger. I appreciate your presentation, Dr. Wisinger. It was so timely, and it's also, it had so much reality, not just everything we want to be doing, but also talking about what's really happening and how that is so important to stay realistic. So really appreciate that.
Sure. So 92 participants without questions. Sounds good.
Okay, we got one coming in.
Uh-oh, hang on.
Here's our first one. You had mentioned bedside rounds. We were told to avoid for safety. Any
Good point. Yeah, I can speak it, or do I need to type it?
No, just talk.
Yeah,
just talk through it. Yep.
No, I appreciate it. So first of all, when I'm mentioning bedside rounds, I'm specifically talking about non-COVID patients currently. In our institution, which mirrored, I'm sure, Banner, Dignity, and others around, the percentage of patients with COVID was overwhelming really in June and July, although has begun to peter down, and we have, maybe about 15% of our population being COVID at this point, maybe 20. And so it means 80% are not, so we have rounds with our other non-COVID patients at the bedside, which I say is very important. We have not had students still to this point participating directly with COVID patients, although we do make sure that as a team, certainly our residents, when we see the patients, and then we will go out and try to engage in COVID-related conversations, making sure the students are there. Not as good as being there with the COVID patients, but at least talking about the disease of COVID and the psychosocial consequences of having COVID, et cetera. So yes, I'm not trying to imply we're having an excessive number of learners in a room with COVID at this point. The next one I see there was Dan
Okay,
Gridley.
you got him? Okay, go ahead.
All right, who let him in is what I want to know. Do you have any recommendations to engage audience members, specifically have you used software platforms to have? So I knew somebody, and I should have figured it was going to be Dan, would say something about, and I was trying to avoid specifically any going down the hole of particular programs, software, et cetera, to answer basically his question, which is using specific software platforms to enhance engagement. So I cannot comment on that at this point. So Dan, I'm sorry, and you can chastise me later. Nicole is asking if there are other people in the audience who have found unique ways to engage residents or students via Zoom. So there's somebody able to, Nicole is asking about using Zoom or features of Zoom that would be more engaging other than just the straight visual back and forth. People can comment on that. The next one I see here, if there was no PPE shortage, do you think we would have restricted students? That's a very good question. I think that what was interesting, at least as COVID first came about, there was still some controversies as to what degree a PPE would be required to meaningfully affect a reduction in infectivity. We now realize that, there was controversy about aerosolization, non-aerosolization. Do you need an N95? Do you not need an N95? I think given the uncertainty that had existed, it was reasonable, despite the shortages issue, to exclude them. Personally now, I feel that I feel that there is some value in having them participate in COVID care directly, particularly when there are physical findings that are of great interest. We do have the ability to communicate verbally with COVID patients, typically virtually through iPads and the like. But I think sometimes there are some physical, especially pulmonary findings and peripheral skin findings of COVID patients that would be nice for students to see. But TPE seems to be an issue. It's going to be an issue for a while. Is there a way to create an opportunity for interprofessional bedside rounds? Okay, the answer to that question from Linda, thank you for asking, is yes. In our institution, we've had periods of time, which although it kind of waxes and wanes, we've had periods of time where we've had nursing students participate with us on rounds to kind of see how it works, as it were, at the bedside, to see some of the questioning and the thoughts that are coming from the physicians, but also gives us as physicians a great chance to get, from a nursing perspective, those issues that are directly related to patient care that matter to the patients and the nurses that physicians can sometimes be oblivious to. So the answer is yes. Whenever possible, we try to encourage nursing and nurses themselves as part of the team caring for the patient, as well as nursing students. Next question, Tina Younger talking about using smaller groups to actually help with asking people the questions. Totally agree. Are you aware of any national board collaborative efforts to get educational content online? Yes, that's a good point. And the resources I gave you from the LCME, from the American College of Physicians, and the AAMC have been looking at trying to have more collaborative online content that can be shared amongst institutions versus having everybody try to do their own thing. So those resources actually can be helpful. Okay. There's some other comments and questions from Nicole to Dan.
Dr. Wisinger, do you see the one from Dr. Pararoidi about creating hybrid instruction? Did you see that one?
Let me look down here. I don't see that. No, okay, here we go.
Got it?
Yep, got it. Creating hybrid instruction. That's a good question. And like I said, when you're old like me and you kind of get stuck in a rut and you feel like everything needs to be at the bedside because that's the way I've always done it and always engaged patients and students and residents, so that's just how it has to be. We have been doing, or myself anyway, we have been actually incorporating some bedside videos and tutorials for patients to help them understand what it is we're talking about, showing them pictures of their x-rays, showing them pictures of organisms, showing them pictures of de-identified skin lesions, et cetera, that they may mirror what they have. So you can engage some of that virtual technology at the bedside too. I've also, to be honest with you, not that it was instructional per se, but I was participating at the bedside with a patient who was COVID positive going into worsening respiratory failure and getting her husband on FaceTime to speak with her. That was actually a very touching, moving moment because this was done right before she got intubated. She subsequently died 2 days later. That was really interesting, but very tough. But it showed that a way to try to have virtualization into what I thought was probably the most relevant part of her care, which was trying to meet with her significant other prior to being on the ventilator. And we've done that quite a bit here, which is very difficult. But we shared that with the students actually after that happened, and I got them to realize that this is a key component of this disease that's affected how we do end-of-life and palliative care training for them. So Dan Gridley wants to know if Jade, the infamous, it's hard to go 5 minutes without somebody asking about Jade. And I would defer to either Jessica or Nicole or whomever with regards to Jade's role going forwd. That's a Dan Gridley question.
Yes, we are, Dan. We are going to be trying to put presentations on Jade, and Nicole is going to be rolling out, resurrecting Jade tomorrow at the Faculty Town Hall. And so you can get more information there. But yes, we will also have this presentation because it was recorded. We will be able to get it emailed out. All right, any other questions? I think everybody's had enough time to put questions in if they would like. So if there aren't any other questions, then we will give you the gift of time.
Appreciate it.
Go ahead and end. Thank you so much, Dr. Wisinger.
Thanks everybody for your help, for hobbling along with me. Thank you.
Thank you, everybody. Bye-bye.